Hello everyone, and welcome to today's webinar, COVID-19 and Transplant Patients, Your Questions Answered. Before we get started, I would like to go over a few items so you know how to participate in today's event. You've joined the presentation listening with your computer's speaker system by default. If you would prefer to join over the telephone, select the arrow next to the mute/unmute icon on the bottom of your screen in the Zoom toolbar. Select Switch to Phone Audio, and then select Phone Call and follow the prompt to dial in. By default, all participants enter the webinar with audio muted. Thank you to everyone who submitted questions by email. Please note that your exact question may not be able to be answered directly, and we will be unable to provide medical advice for specific issues. In order to address as many questions as possible, we have reviewed all the questions that have been submitted and will answer those of a similar nature collectively. Thank you for your understanding if you do not hear your specific question mentioned. For those of you joining on your computer, you will have the opportunity to submit text questions to the presenters by typing them into the questions pane found in the Zoom toolbar at the bottom of the meeting window. Please avoid using the chat box to submit your questions. It helps us to monitor them more effectively when they are all submitted in the question pane. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of the presentation. In order to protect your privacy, when you ask a question, please do not use your name or provide any other personal identifying information. Today's webinar is being recorded, and you will receive a follow-up email within 24 to 48 hours with a link for on-demand viewing. I would like to introduce our moderator for this webinar, Lydia Lauder, National Director of Programs and Public Policy at the Kidney Foundation of Canada. Lydia, over to you.
Thank you very much, Janice. The Kidney Foundation of Canada would like to thank our sponsors for making the 2020 Kidney Foundation webinar series possible: AstraZeneca, Horizon, Otsuka, and Paladin. COVID-19 is a serious health threat, and the situation is evolving daily. In these uncertain times, it's normal to feel anxious, especially for those with underlying health conditions. Talking to people you can trust and getting the information you need can help. The Kidney Foundation, in collaboration with the Canadian Society of Nephrology and Canadian Donation and Transplantation Research Program, is proud to present this webinar, COVID-19 and Transplant Patients, Your Questions Answered. This webinar will give you the opportunity to ask questions to some of Canada's leading nephrologists and transplant specialists, and the content is intended for a Canadian audience. It's my pleasure to introduce our presenters today. Dr. Dipali Kumar is a Professor of Medicine at the University of Toronto. She is an attending physician in the Multi-Organ Transplant Program, Transplant Infectious Diseases Service at University Health Network. Dr. Vikas Sridhar is currently completing a kidney and pancreas transplantation fellowship at the Toronto General Hospital and is a PhD candidate at the Institute of Medical Science, University of Toronto, with a focus on cardiorenal protection in transplantation. Dr. Ishtvan Mushi is a clinician investigator, transplant nephrologist at the Multi-Organ Transplant Program and Division of Nephrology at the University Health Network in Toronto. For the doctor's complete bio information, please visit our website at kidney.ca webinar pages. I'll hand it over to our presenters.
Thanks very much. Hi everyone, my name is Dipali Kumar. I'm from the University of Toronto. So what I'm going to be covering is some general information about COVID-19 and then what we know about COVID-19 in transplantation. So for the first part, I'm going to talk a little bit about where COVID-19 came from, how does infection actually occur, what are the symptoms, can you have COVID without symptoms, and how do you get tested, whether you have symptoms or not. Next slide. So where do coronaviruses come from? Well, you've probably heard on the news that coronaviruses originally come from bats. Bats actually carry many hundreds of types of coronaviruses. Now, how would a bat transmit to a person? So it really doesn't happen directly because not all of us are in close proximity to bats. What happens is that bats are maybe in close proximity to other animals like cats, dogs, camels, and other types of animals. So bats can actually pass on these coronaviruses to these other animals. And then these other animals are in close contact with humans. And so then the coronavirus gets passed from the bat to the intermediate animal and then down to humans. And that's what's happened to with COVID-19. It's thought that COVID-19 originally is from a bat, which then was passed on to an intermediate host, intermediate animal. The animal is thought to be either a pangolin or a raccoon dog, and it's not clear yet how that occurred. But then from those intermediate hosts, it has been passed down to humans. Next slide. So how does COVID-19 actually spread? In the picture you can see on your left, COVID-19 is very easily spread by respiratory droplets. So respiratory droplets occur when somebody coughs or sneezes. The droplets then travel in the air. They mostly are large droplets, so they kind of fall down. But if you are close to that person, and it's thought, close means within 2 meters, that you may, these respiratory droplets may actually touch your mouth, nose, or eyes, and then you may get infected that way. The other way to get infected is if a person carrying COVID touches, a handrail or a doorknob or a particular surface, and then somebody else comes along and touches that surface as well, and then goes on to touch their face, their eyes, nose, or mouth, and that's a second way of getting infected. So what can we do to prevent this from happening? Well, we can limit our sneezing and coughing, and if that's what's happening, then cough or sneeze in your elbow or into a tissue, dispose of the tissue directly into the trash can, and wash your hands. And washing your hands means washing for at least 20 seconds with soap and water. And hand sanitizer, if there's no soap and water available, is also very reasonable. Once a person does come into contact with COVID-19, the incubation period before symptoms show is about 5 days, and the range is anywhere from 2 to 14 days. So what that means is that the virus is incubating in the person, but they're not showing symptoms. So even during this incubation period, you are actually infectious and can pass on the virus. And that's now been shown for COVID-19, and that's probably why it's been spreading so quickly. Is that people are interacting with others before they even know that they're sick. Next slide. So what are the symptoms that can happen with COVID-19? Well, if it's just mild to moderate disease, which occurs in most people, 80 to 90 people have this mild disease, there can be fever, chills, sore throat, dry cough, shortness of breath, body aches and pains, diarrhea as well as headache. There's been some unusual symptoms reported, like people have lost their sense of smell and people have lost their taste buds. Now, COVID-19, as I'm sure you've heard, can be very severe, and that happens in 10 to 20% of people and can cause confusion. It can lead to a lung infection or pneumonia, kidney disease as well, and inflammation of the heart muscle, which is called myocarditis. Next slide. Now, can COVID occur and you don't have symptoms at all? Yes, that has been known to occur. So there are people who have very mild or no symptoms at all. And these are what we call asymptomatic people. These people are usually younger, and since they don't know that they have anything wrong with them, they actually don't need to visit the doctor. Some people are what we call pre-symptomatic, so they are within the incubation period, but will develop the symptoms in a few days. Now, the important thing is that both of these groups, either asymptomatic or pre-symptomatic, are infectious and can spread the virus to others. Next slide. So how do you get tested? So at this time, testing is only done in those who actually have symptoms consistent with COVID. Now, you can imagine if we were to test asymptomatic people, we would be testing a lot of people, whether or not they have COVID. So at this point, testing has only been restricted to people with symptoms that may be COVID. COVID test centers have been established to take the pressure off the emergency room. And the test that's being done is called a nasopharyngeal swab, and that's currently the best way to test for COVID. So in a nasopharyngeal swab, a swab is essentially inserted into the nose to try to get a sample from the back of the nose. People are looking at other ways to diagnose COVID. So saliva has been looked at to try to see if we don't have to actually do a swab, we can just take a sample of saliva. But that's under research right now. So before getting tested, if you do have these symptoms, it's actually important to contact your transplant coordinator, because the symptoms of COVID also resemble symptoms that you can get with other infections. And so it's important that we also rule out other reasons for these symptoms. Next slide. And some of the strategies that have been implemented to reduce the spread of COVID include isolation, physical distancing, frequent hand washing, as well as masks. Isolation is a term, you've probably heard these terms, isolation and quarantine. Isolation is a term that means separating sick people from healthy people. So if you're in isolation, you're staying in a sick room, away from people, away from pets, and using a separate bathroom. Quarantine, on the other hand, means restricting the movement of someone who might have been exposed. So, this means that you monitor yourself very closely for symptoms. Now, physical distancing has also been implemented as a strategy to reduce COVID spread. Physical distancing, by that we mean a distance of at least 2 meters from others. So some of the things that, as you know, people have been doing are working from home, avoiding large gatherings, using delivery services for medications or for groceries, not going to school. Schools have been closed, so online schooling. And all these measures are meant to promote physical or social distancing. Frequent hand washing as well, washing your hands after touching your mouth or nose, washing your hands before and after food preparation, etc. And then there's masks. And I know there's a lot of questions out there about masks. So there's 2 types of masks. There's N95 masks, and as well as surgical masks. And now we have the cloth mask. Next slide. So I just want to tell you a little bit about the difference between N95 and surgical masks. So on your left, you see an N95 mask. An N95 mask is really only for healthcare professionals in the context of COVID. An N95 mask to work properly actually requires fit testing. So we as healthcare professionals have every 1 or 2 years, we undergo fit testing to know exactly what the size of our mask is and to make sure that the mask forms a very tight seal around on our face. So if you're actually wearing this mask properly, it's quite uncomfortable. And so use of this mask is not recommended for the public to prevent infection. Most people who are using N95 masks currently in the community are probably not wearing them properly, and so these masks are probably not a lot better than the next type of mask, which is a surgical mask. So a surgical mask you've seen, I'm sure, very commonly in doctors' offices and the hospitals. These are the types of masks that we can wear in the community to prevent spreading germs, etc. Now, they're not 100% in terms of getting an illness from others or for spreading illness, but what they actually do is they prevent a person from touching their mouth or nose with their hands. So the surgical mask or cloth masks are actually reasonable as well if you don't have access to a surgical mask. I also get a lot of questions about gloves, and gloves are not something that are routinely recommended because gloves are, gloves can also get dirty, and you may actually inadvertently touch your face with the dirty gloves and actually transmit infection. So it's actually better to just do good hand washing. Next slide. Okay, so let's move on to the next part, which is transplant recipients and COVID-19. So are transplant recipients at higher risk of COVID-19 because of immunosuppression? So this is a question that we get asked all the time. So what I can tell you is that in the transplant recipients we've seen with COVID-19, there's a huge spectrum of illness. Some transplant recipients have very mild illness, and some do have severe illness. At this point, the scientific community is trying to figure out what the risks are, what are the risk factors that will cause somebody to have mild illness versus severe illness. And that's an ongoing work throughout many countries, including Canada. So I think that answer will probably come hopefully soon. But what we know now is that transplant recipients get very similar symptoms to anybody else, including the respiratory symptoms, the diarrhea, the loss of smell, the loss of taste. So we know that that's happening as well. Should transplant recipients wear masks or gloves in public? So I think we've covered that, that masks should be worn actually by transplant recipients. A surgical mask is fine, or a cloth mask in public, and that gloves are likely not essential because you may actually contaminate your face with gloves. Should transplant recipients avoid high risk or public work? So I think we've received many questions about this, and this is a very common question. It's hard to, I have to say, it's hard to put a blanket statement on this sort of thing. It really depends on the type of work that you're doing. In general, if it truly is high risk or public work where you're not able to avoid contact with a lot of people, what you might do is ask for an exemption from work. And hopefully employers will be understanding. I think these days employers, many employers are understanding. You may ask to be reassigned to something else that may be, within your work environment that maybe doesn't need for you to interact with a lot of people. So there are ways to, I guess, mitigate the exposure risk. Should a working family member of a transplant recipient self-isolate in case they get sick? So there are transplant recipients whose family members may work in healthcare or are other essential workers. And definitely, those family members really need to be vigilant, really need to monitor themselves for symptoms. They need to practice good hand hygiene. They need to practice good infection control practices at their work as well. And if they're feeling even a little bit sick, or they're worried that they're sick, then they should stay in a different room and use a different bathroom and get tested. And lastly, what do I do if I have COVID-like symptoms? If you have COVID-like symptoms, then definitely contact your transplant program, your transplant physician or transplant coordinator, and get advice on where to go get tested, or if you need to have other tests done. So it's very important to do that and to get advice on what to do next. Next slide. So I will hand this over to now my colleague.
Thank you, Dr. Kumar. I'd like to thank the Kidney Foundation of Canada for this opportunity to present. I'd like to talk a little bit about contracting COVID-19. And I'd like to go over a few of the questions that I've listed over here. Firstly, am I at risk of contracting COVID-19 as a transplant patient by going to the hospital for blood work or appointments? And specifically, I'd like to talk a little bit about access to medications, what has changed with outpatient kidney transplant clinics, and what do I need to know as a transplant patient about going to get lab tests. And then I'd like to talk a little bit about steps to take if a family member or household contact actually gets COVID-19. And I'd like to talk a little bit about how to find out if someone is immune to COVID-19. Next slide, please. So let's talk a little bit about avoiding the virus as a transplant recipient. Next, please. So I can specifically speak about the experience at the Toronto General Hospital. And what we're trying to do is we are minimizing clinic appointments where patients actually need to come into the hospital. And when safe to do so, we are also reducing the frequency of blood work. And instead of appointments where patients are coming into the hospital, I'm sure many of you have noticed that we are switching to phone assessments and telehealth appointments as a way to actually follow up on our patients and see how they're doing and deal with any medical issues that may arise. Next, please. So certainly we try to avoid unnecessary lab tests, as we would be doing anyway, whether or not we had this COVID situation. However, lab tests may be unavoidable. Particularly, this may be important if people have had recent transplants, because this is a good way of actually following kidney function or organ function, as well as levels of immunosuppression. So I do give patients some tips as to how to cope with getting blood tests that may be unavoidable. So firstly, there are some, as far as I know, there are no specific lab centers for patients that are at increased risk of contracting the virus or immunosuppressed patients. As far as I know, that does not exist. That being said, one possible option may be to actually contact your lab center and see if they actually have an ability to book your appointment in advance, so you can ideally avoid lines and go directly to your appointment. This very much varies center to center, and it varies by the company administering the lab testing as well. If such options are not available, it may be prudent to seek less busy hours, and if possible, this is difficult, but avoiding public transportation going to and from the lab testing. As Dr. Kumar mentioned, it's important to wear a mask, a surgical mask or a cloth mask, and frequent hand washing is really key. A lot of the test centers actually have bottles of Purell as well as hand washing stations at regular intervals. And it's important to follow test center regulations on social distancing while actually having the blood tests done. Next, please. In terms of medications, it would be important to take advantage of home delivery of medications when possible. And I do know that there are some pharmacies that do offer this option. If not, it may be worth having a friend or relative pick up your medications if possible. Some questions were submitted whereby certain pharmacies are providing limited supply of medication, so 1 month as opposed to 3 months. And at that point in time, it may actually be worth getting in touch with your transplant coordinator as well as your pharmacy, just to let them know that you are an immunosuppressed patient, and it may be worth minimizing the frequency of visits to your local pharmacy. I'd like to stress that it is important, even under these times of stress, to forget to take your medications. Forgetting to take your medications, especially your immunosuppressive medications, may actually lead to things like rejection and the need for more hospitalization and increased risk of actually getting more immunosuppression and at increased risk of contracting the virus. Next slide, please. I'd just like to remind everyone to mind your cell phone. Next, please. This is actually what I do with my own cell phone. I put it in a Ziploc bag. Oftentimes I see patients, rather people outside in the grocery stores or walking on the street. They have masks on, they have gloves on, and they're on their cell phone. So I just want to remind everyone to be mindful of their cell phones. Next, please. So I'd like to talk a little bit now about dealing with a family member or a household contact that actually gets COVID-19. The simple step, which may be easier to say and harder to do, is actually to stay away from them. Ideally, if you can, or if they are able to, it would be good for them to stay at another house or apartment. However, the reality is this may be difficult for the majority of us. So what we'd like to do is Health Canada actually recommends that if you need to continue staying with someone else who has COVID-19, it is important for them to try to isolate within the house or the apartment. So one strategy would be to try to isolate them in the basement. And it's definitely important for them to use separate bathrooms, cutlery, as well as entrances where possible. Ideally, they should be wearing a mask, and it is important to follow frequent hand washing on everyone's part, as well as to avoid the contamination of common surfaces. Someone put forward the question, what if I am the primary caregiver for someone with COVID-19? This may be very hard to say, but it's actually important as a transplant recipient to avoid providing care for a loved one with COVID-19. We know from studies of reports on transplant patients getting COVID-19, almost 90% or more than 90% of them actually ended up acquiring COVID-19 from a family member or a household member. If your loved one or your household member is unable to cope with their COVID-19 illness, they may need to go to the hospital to get further care. It's important to stay safe and for everyone else around you to be safe as well. Next slide, please. I'd like to talk a little bit now about being immune to COVID-19. And there's certainly been a lot of stories of this on this subject in the news. Next, please. So as Dr. Kumar mentioned, asymptomatic infection or infection without any symptoms of COVID-19 is a reality. Where it's unknown at this point in time, the rates of asymptomatic infection in the transplant recipients. And we're only now starting to get a sense of asymptomatic infection among the general population. Next, please. It is important to note that based on the current science, previous infection may not necessarily be a guarantee against reinfection. There's the additional factor in transplant patients that they are further immunosuppressed due to their medications to prevent rejection. Next, please. Is it possible to assess for evidence of immunity against COVID-19? So there are antibody tests available, and there are a large number of tests available. Next, please. Next. So in this slide, I actually talk a little bit about how antibody tests work. And the idea is there are two types of antibodies that our bodies produce against infections. And based on the type of antibody, we're actually able to get a sense as to whether you had a recent infection or an ongoing infection, or if you had a previous infection. Next, please. Next. So while that sounds really good and really interesting, it is important to note that antibody testing at this point in time is not reliable, is not standardized. And more so, even if we do detect antibody, it's unclear whether this antibody will help you be immune to COVID-19. So at this point in time, there's still a big question mark around this, and the science is working on this. Next slide, please. Let's talk a little bit about treatments for COVID-19. And specifically, I'd like to talk a little bit about treatments versus vaccinations. I know that there have been a lot of questions on this. Next slide, please. Next. The short answer is, at this point in time, there are no proven treatments for COVID-19. Next, please. The longer answer is there are actually a large number of therapies that are currently under consideration of clinical trials. And I'm sure at various points in time, you have come across these. Next, please. Next. Next. So these are just 3 large studies that I've pointed out that are currently ongoing, looking at a large variety of therapies. When transplant patients get COVID-19, there are different strategies as to how to manage their immunosuppressive medications. And that really depends on whether people have mild, moderate, or severe infections. And that's usually done based on the decision of the transplant team, as well as the infection control team and the team within the hospital. Certainly, at this point in time, we are not prophylactically reducing immunosuppression in patients to prevent getting COVID-19. And as I mentioned earlier, it is important to keep taking your immunosuppressive medications to prevent more serious issues like rejection, which may end up with you in the hospital. Next slide, please. Next. One back, please. Next. Okay, so the next thing I wanted to talk a little bit about is vaccines. And I know that there's been a lot of interest in this. So the way a vaccine works is that it trains your immune system to fight the COVID-19 before you end up even getting the infection. There are actually a large number of vaccine trials currently underway. So when I went to the London School of Hygiene and Tropical Medicine, which has a nice tracker of all the vaccines under development, I found 118 vaccines that are in various stages of development. What I have over here are 9 vaccines that are currently undergoing human trials, and results of these trials are pending. The question obviously arises is whether these vaccines can be used in transplant patients. That really depends on the type of vaccine. Certainly, we'd want to avoid vaccines that include replicating viruses or attenuated viruses, as those may be problematic in patients that are immunosuppressed. However, the majority of the vaccines that I have in this picture, actually all of the vaccines that I have in this picture, do not fall under this category. And hypothetically, one could consider using them in transplants, provided that they are proven to be efficacious. Someone raised the question as to whether vaccines are going to be effective in transplant patients, even if they are approved for use. So we know from the flu shot that perhaps using the higher dose of the flu shot vaccine works better in giving immunity to patients that have received transplants. And it remains to be seen if vaccines that are safe for use in transplant patients for COVID-19 may also similarly require a higher dose than the general population. The other benefit of vaccines is that by giving them to the entire population, you lead to a phenomenon known as herd immunity, whereby by a large number of the people around you being immune to the COVID-19, it actually prevents spreading COVID-19 to even patients that may be at increased risk, like transplant patients. So certainly, we're all very interested in this area and look forward to seeing some of the results of the studies on vaccine developments in COVID-19. Next slide, please. At this point in time, I'd like to hand this over to Dr. Mucci, who's going to talk a little bit about the state of kidney transplantation in the midst of this pandemic.
Thank you very much, Dr. Sridhar. Good morning and good afternoon, everybody in the respective time zones. And thank you for the Kidney Foundation for organizing this webinar and asking us to talk here. I'm Istvan Mucci. I'm a transplant nephrologist at the University Health Network in Toronto. And I will briefly talk about what is happening to kidney transplantation right now and what has been happening over the last few weeks, and what are the plans around kidney transplantation as we go forward. And also I would like to spend some time on discussing strategies and approaches to maintaining physical and mental health, maintaining sanity under these very unusual and very stressful circumstances. So the first point is, come back please, yeah. So what is the state of kidney transplantation currently? Of course, the question is, has it changed? Did it have to change? And the questions there, why did it change if it changed? And we know that in different jurisdictions, the approach to kidney transplant or organ transplantation has been different. So there has been no uniform approach to slow down, stop, or keep the transplant programs active. In Canada, most of the transplant programs followed a similar approach, and starting around early or mid-March, most of the kidney transplant programs has stopped most of their activities, except some exceptional situations where either the patient who was waiting for a kidney had a very high level of antibodies, where they were very sensitized, and so they had very little chance to get a transplant. And if there was a kidney for them, that would be considered. Or if there was a medical emergency, and if the patient who was waiting for the transplant would have otherwise died or had severe health consequences, those transplants could have happened even in the past few weeks, but otherwise most of the kidney transplant activities have been stopped in most of the transplant programs in Canada. So there are plans to change this, and in fact changes is happening and has happened already. So why was it necessary to stop transplant activity? There were several reasons overall. One important issue to consider, that this was a very new situation. We didn't quite know, and still don't necessarily know exactly how COVID infection would affect patients who are getting a transplant, who are in the hospital. What is the best approach to medications, to immunosuppression in transplant recipients? So one of the main reasons to stop the transplant activities was to avoid unnecessary risk to the transplant recipient. One additional risk that we wanted to prevent or avoid any risk to living donors if living donor transplant was considered. And we had to make sure that we have the appropriate testing facilities to test both the donors, both deceased donors and living donors, and test the recipients. And especially this is important after the so-called community spread has become more frequent, to make sure that a potential recipient who comes in for a transplant does not have the COVID infection. Because at this point, still, we don't quite know how would that patient respond to the anti-rejection treatment if they had a COVID infection. And in general, as many of the participants or many of the audience members know, in general, we do avoid transplantation if there is active infection, because we think that, or we know that the infection would spread much more rapidly, and likely this would be the case for COVID as well. There was an additional consideration when certain transplant activity was slowed or stopped, is that the hospitals that were involved in transplantation, they wanted to make sure that capacity was available if there was a search for patients who would appear with COVID infection. And so transplant, especially kidney transplant surgery, was considered to be elective because you still had the dialysis to maintain your health at a certain level. And the hospital resources were kind of saved for a potential surge for COVID infection. So this is, as I mentioned, changing now, and in multiple jurisdictions in Canada, there are plans to reopen transplant activities. In Ontario, kidney transplantation activities has been slowly restarted. And there's a staged approach to this. First, we will try to do transplants that are considered to be the most smooth, least complicated procedures, and where we expect the shortest hospital stay after the transplantation. So these are already happening in most of the Ontario transplant programs. In the next stage, potentially living donor transplantation will be considered, which is not happening at this point. The question is, what are we doing to make this as safe as possible? And the most important things that what the system is doing is that we are testing all the participants, both deceased donors and the recipients, for COVID. We do not accept donor organs from donors who have COVID infection for kidney transplantation. And as I mentioned, kidney transplant recipients who are called into their transplant to the hospital will be tested for COVID, and the transplant will only go forward if the tests were negative. Another step that we are considering to make it as safe as possible, that the programs in their own circles, they will consider what type of changes are necessary to the medications that we use at the time of transplant or soon after. And this is obviously done at this point at the program level. So each programs are considering their policies and protocols, and we'll make changes to that accordingly. Living donor transplant, as I mentioned, in Ontario or in most programs in Ontario are not happening at this point, but reopening living donor transplantation is being considered in the next stage of increasing transplant activity. And of course, when someone considers a transplantation, a kidney transplant, or a recipient considers whether I would want to accept an offer, the question comes whether this organ that I'm receiving, the kidney that I'm receiving, whether that could transmit the COVID infection. And although there are no absolute certainty about this, but certainly there is no reported case for transmission of transplanted organs, of COVID virus with transplanted organs. And as I mentioned, we do screen, do test the donors, and we only accept donors that are COVID negative. So the risk of transmitting COVID infection with transplantation is extremely low at this point. And the safety of the living donors is obviously an important question and an important focus of the programs. That is why we are not doing living donor transplants at this point. And once this activity is reopened, testing and the appropriate precautions will be made and in place to protect the safety. Next slide, please. And this slide talks about a different set of questions, because obviously this is true for not only transplant recipients, their family members, or their donors, but it is true for everybody that these times are very stressful and have a huge impact on all aspects of our life. And we need to make a very conscious and concerted effort to maintain our physical and mental health. And of course, this is very important for transplant recipients who have to live with a chronic medical condition, and maintaining their physical fitness, physical health, and try to cope with the stress that we have is very important, because both of these aspects will have an impact on overall health. It may have an impact on the health of the graft. And so these strategies are quite important. These are probably well known in the broader community, but I thought it would be worthwhile to quickly go through. And I think importantly, structure, which is kind of lost for many of us when we don't go to work anymore, when we don't attend to the everyday activities, the structure is missing. And so creating or recreating that structure in your life, it is very important for mental health. Maintaining some physical activity inside the home, whether that's just walking up and down the stairs, doing squats or other simple exercises, is an important part of physical health and physical wellness. And similarly, nutrition, and as for kidney transplant recipients, importantly, is emphasized all the time, good hydration and appropriate fluid intake is very important. Sleep is essential for our life, and maintaining regular sleep hours, good sleep, the sufficient amount of sleep is important both for mental and physical health. And there are some additional kind of steps that you can do. Listen to music, pick up other tasks that you were planning for and you might have the time for now. Learning languages or reading long books is potentially a good way to stay kind of more calm than you would otherwise be. And lastly, about this slide is the information that we face. And clearly, at some point, it seems that there is an overload of information around COVID, and you need to make sure that you stay informed and you know what is happening. At the same time, look at only information that is trusted, that can be relied on. And as mentioned before, Health Canada, your transplant program, and the patient organizations are important and trustworthy sources for information. Next slide, please. And the last piece is, again, coping with the stress and coping with a situation which is certainly bigger than us. What can you do? What are the broader approaches that you take? And it is important to kind of split it into three different stages or approaches, how you cope with the situation, because this will help you to reduce the amount of anxiety and stress around this. It is important to differentiate between things and concerns that we may have control about and others that we don't have a control about. And when we have these things identified, try to focus on things that you can manage and you can control, and try to apply the advice that you heard during these talks as well, and the advice that you find in other resources, such as the hand washing, social distances, and other practices. And that can certainly prevent infection, and it also might reassure you that you're doing the right thing, and also other people around you will be doing the right thing as well to protect you and protect each other. When you look at issues that are beyond us, whether we will have a second surge of infection, whether we will have a third surge, what will happen to the economy, those are things that are beyond our control, and it's important to try to manage our emotions around those, and avoid blame and criticism, offer and accept help if that's needed, and keeping a sense of humor is a good way of coping with things that are sometimes difficult to think about. And if you have to deal with issues that are heavy, that will be unavoidable, such as illness or potential death around you, there are other ways of managing, and this is when we reach to the depth of our experiences, to the deepest values, the purpose of our life, and many of us will gain strength from our faith systems. The link there connects you with a focused approach around coping developed by Dr. Mander and Hunter and the Mount Sinai Hospital here in Toronto. Next slide, please. And I hand over the rest to Janice or Lydia, I believe.
Thank you very much, Dr. Mushi, and it's been a pleasure to have you all speak and answer a lot of the questions that have already come through. But I see our audience today has a real thirst for knowledge and is really asking a lot of questions out there. And one of the biggest themes that I'm seeing recurringly, both with the questions that was submitted prior to the webinar and during the webinar as we've been going through, is a real thirst for knowledge about what to do when it's time for reintegration. There's a lot of questions about going back to work, living day-to-day life, such as attending, going to grocery stores, seeing grandkids, staying with a partner, there's a lot of that kind of information. And, I've heard it, what I heard through the presentation is that a lot of this information can come via the transplant coordinators and the transplant units. But I was wondering if any of our presenters would like to comment further about going back to work and reintegrating to society as a whole.
Hi, everyone. I think I'll try to tackle this question, and hopefully my colleagues can jump in. So, I think it's important to recognize that we're in such uncertain times right now, and this is not something that anyone has 100% experience in. But I think there's some principles that we can follow, as things reopen, as schools reopen and we're asked to go back to work and so on. I think the principle of social distancing should hopefully remain, especially in the transplant setting. So anything you can do to continue to maintain social distancing will be important. I think wearing a mask, continuing to do that as things reopen will be important. It's all about risk benefits. And if there's something you can do at your work, again, to modify your work so that you are not, that you maintain that social distance, I think that's another principle that we can follow. One of the things that I've heard suggested is that once things open up, transplant recipients wait for 2 or 3 weeks before fully sort of being out there just to see what happens. Do we get a surge in cases in community transmission again? So it may be prudent to just wait and see what is happening once things do open up in your area.
Thank you very much. Really do appreciate that. And just a question for Dr. Mushi. I've had a couple of live donors submit some questions prior to this this webinar, and what they were asking is if they are living donors, would they be considered high risk for COVID because they're living with one kidney?
Yeah, thank you for the question. As many of us repeated several times, there's very little known facts around the COVID infections, very few things that we have absolute certainty around. And so for this question as well, the first part of the answer is that we don't quite know, because there have been no reports about infection and the complications in patients who donated an organ before. In general, though, the kidney function of living donors are normal or very close to normal. Living donors had gone through multiple testing, and they are healthier than the general population. So based on that, it is quite likely that the risk would not be substantially higher to contract the COVID and also to have more severe complications from the COVID. So likely the risk would be similar to the risk in the general population.
Thank you very much. And I have another question, which is what is the standard treatment for COVID-19 and what effects would that have on transplant patients if we know about that yet? And I might ask Dr. Sridhar, but I'm sure that all the panelists could weigh in on this one as well.
Thank you. Yes, I've actually been trying to type some of these answers in the questions. I saw that someone had asked about some infections, some treatments for the COVID-19 infection. I'd like to stress that at this point in time, there's nothing proven for the treatment of COVID-19, even in the general population. There are several trials going on, for the most part in the general population. Some therapies that have been put forward include hydrochloroquine, convalescent sera, certain antivirals that are used for HIV. There's a medication that was originally designed for Ebola called remdesivir. All of these are currently under study. There's also medications that treat the so-called cytokine storm, or the storm of inflammation, and they try to reduce these inflammation, particularly when the patient is sick, and this is also being studied. I think the use of these medications at this point in time is very much on a case-by-case basis, and the primary consideration in transplant patients would be to be very vigilant and aware of interactions with the medications that they already take, specifically their immunosuppression medications. The last thing we want is, when we're using a therapy with questionable evidence, to result in unintended side effects, like interacting with your medications and lowering your levels, which in and of itself may lead to complications like rejection. So we're very careful with that. We work together with our infectious disease team, as well as with the transplant physician to make this make these suggestions. Another related question which someone else also asked is, what are we doing with immunosuppression? So we generally, with mild infection, we aren't changing the immunosuppressive medications. Certainly with progressive infection or more moderate to severe, we do sometimes consider reducing the immunosuppression. And generally the first thing that we reduce or stop are medications like Cellcept, Myfortic, or the Imuran. And just to clarify, we only do this in transplant patients that are diagnosed with COVID and have progressive moderate to severe infection. A lot of this is based on opinions. There isn't, once again, a lot of published studies that recommend one immunosuppressive strategy over the other. It's very much general opinion among physicians that deal with this a lot. And we take a lot of guidance from when our transplant patients get other infections apart from COVID-19, like really bad bacterial infections or other viral infections.
Okay, thank you very much for that. And yes, we are getting a lot of questions about the cytokine storm and how it's going to affect transplant patients in particular. And there's been some interesting theories posed on this about whether being immunosuppressed, whether that could cause bodies to mount a cytokine storm, or that by having a suppressed immune system, would that counteract any of the problems with COVID? And I'll open that up to all the panelists.
I'll go ahead.
Okay, yeah, maybe then I start. I just wanted to also add another comment to Dr. Sridhar's discussion about the medication, that it is important to consider, and I think it is related to this cytokine storm as well. It is important to keep in mind, and that's also kind of one way of coping with the threat that obviously the COVID poses, is that the majority of the cases, the majority of the patients who will get the COVID will have a very mild or relatively mild disease. Frequently, even transplant recipients stay at home. They don't have to come to the hospital. And the disease actually takes its course, and one gets better. So while the cytokine storm and potentially changing medications and potentially considering studies and treating the virus is important, it is important to keep it in perspective that, that it doesn't happen to everybody, and the cytokine storm doesn't happen in all the transplant patients or all the patients who will get infected. And also it is important to keep in mind that these changes in immunosuppressant medication, whether to reduce it or not, it should be done in the hospital, it should be done by the professionals, and everybody needs to talk to their transplant team before considering anything else. And certainly coming back to the question, the cytokine storm is happening at a late stage of the COVID illness, when basically the inflammation kind of takes its own course. And there is speculation whether the immunosuppressive medications, or some of it at least, might reduce it, or changing the immunosuppression may kind of let the storm loose and even more severe. There is not enough information at this point, at least to my knowledge, and Dr. Kumar and Dr. Sridhar may comment on that. There's not enough information for us to exactly know what is the best strategy, whether we need to change the one medication or the other. Certainly, as Dr. Sridhar mentioned, some of the medications are reduced at the time of severe infection, and that is usually done in the hospital. Not always, but usually done in the hospital. And I leave the microphone, or pass it on to Dr. Kumar.
So thanks, Istvan. So I completely agree with that. So what we're seeing in transplant recipients, as I mentioned before, is that it's a huge, the whole spectrum. So we're seeing people who have very mild disease, and we're seeing the cytokine storm. It's actually very difficult to tease out whether immunosuppression is playing a role. And, in whether people are getting cytokine storm or not. I think we're only going to know that with a lot more research. Some of the other things that may impact the outcomes might be, how far a person is from their transplant. So, does an early time, if you just got your transplant within the last few months, does that put you more at risk versus if your transplant was many years ago? Could it be the age of the person? Age, as you know, age over 60 is a risk for the cytokine storm happening. So it may be that transplant recipients that are older age may be more susceptible. I think those are the things that we're trying to tease out right now. And there are, I'll just say that in Canada, we have undertaken an initiative where we are trying to get information on all the transplant recipients that have had COVID to exactly try to sort out this question. So what's happening is that we're asking all the transplant centers to, collectively put together the information that they have on transplant recipients that have already had COVID, so that we can learn from that.
Okay, thank you very much. And just on the same vein, in regards to research and transplantation, we have had a number of questions posed to us prior to the webinar in regards to if there is any research of changes coming to transplants anytime soon. And even though these Dr. Leanne Stalker and Dr. Stephanie Meyer of the CDTRP were not presenting, we have welcomed them to the podium just to speak to what transplant research is taking place at the moment.
Hello, everybody. This is Leanne Stalker here from the CDTRP. So yeah, we were forwarded a question from the Kidney Foundation. So first off, thank you for inviting us to this seminar. It was really fantastic to hear all of the speakers today, have this opportunity to interface with patients on this at this level is just fantastic. So in terms of research that's happening in direct relation to COVID-19, there are several studies going on that are focused on transplant recipients or immunocompromised populations. This includes national studies on sample collection, as well as data collection to look at how a pandemic of this sort does affect this population. We also have several other studies going on, starting to look at the effects of mental health and psychosocial effects on a community of this sort during this unprecedented time. So in terms of direct relation to COVID-19, yes, we definitely have several research initiatives that have already been funded or are on their way to being funded and will address the needs of this community during a pandemic of this sort.
Okay, thank you very much, Dr. Stork. I really appreciate you chiming in. And I'm going to circle back to the cytokine storm. I've seen there's a lot of questions about what a cytokine storm is in the Q&A panel. And if one of the doctors could kindly oblige our participants today in just explaining a little bit further what the cytokine storm is.
I'd be happy to. Yes, I have seen a number of these questions, and I think it's worthwhile just clarifying what this is. So our body is able to respond to infections, including the virus, in a large number of ways. And part of this response does include releasing proteins called cytokines to help the various tools that we have in our body to help fight infections. Now, like everything, there are certain negative effects to the body releasing cytokines. And sometimes what happens is that in some people, the virus actually causes the person's body to disproportionately release these cytokines. And what ends up happening is that the side effects or the negative effects of cytokines sometimes are far greater than the benefits. And some of the negative effects of cytokines that have been noted, particularly in COVID patients, is that they can actually worsen the inflammation in the lung through a variety of things, like a lot of leaky blood vessels within the lung, which causes the pneumonia or the response of the lung to the virus to actually be worse than it would have otherwise been. And this can actually lead to the problems with these patients breathing and having enough oxygen in their bloods and this requires us to put these patients on the ventilator and use certain tools like proning them. So one strategy that we have come up with in treating this out of control cytokine release is to actually use certain anti-inflammatory medications to help reduce the release of these cytokines and hopefully allow the lungs to heal themselves and allow these patients to breathe on their own. So that is what we mean by targeting the cytokine storm.
Okay, thank you very much. I really do appreciate it. I'll direct this next question to Dr. Mushi, as it is a living donor and a live donation question. We've had a few questions about when live donation is likely to start up again and what living donation would look like in the future. For example, will the donation process change if there's a COVID positive donor who's recovered? Would there still be any COVID antibodies in either donor or the recipient? And will that change the live donation process? And does the transplant team now anticipate testing for COVID antibody serology, and how will this overall affect any of the living donor process? If you're in a position to discuss that, we'd appreciate that.
Thank you for the question, and certainly living donation is playing a very important role in overall kidney transplant, so that these are very pertinent questions. And unfortunately, to some extent, the answers are uncertain and remain uncertain. About the timing of opening up living donation, this is an ongoing discussion. As I mentioned, in Ontario, living donation is still not happening in most programs, and it is considered for the next stage. And that next stage will happen when the situation is even more stable, and when we see that the number of new infections are declining perhaps in the community. And hopefully that will happen reasonably soon, but it would be very difficult to put any timeline to it. And it is being monitored very closely. How will living donation look like in this new kind of post-COVID or COVID era? I think some of the answers to the question will depend also on knowing what exactly the antibodies mean, whether the people who went through the infection, who recovered from it, will remain immune. The presence of antibodies themselves will not prevent a person from donating, and likely it will not pose additional constraint or limitation on the donation. It's quite unlikely that the virus would reside in the kidney, and quite likely that organs from people who got the infection but recovered could be used for transplantation. And I guess Dr. Kumar might pitch in into this question as well. So hopefully the workup process will not have to change too much. Workup of the living donors is quite thorough already, because we want to make sure that both the donor and the recipients are safe during the living donor process. And we'll certainly consider, I think, testing for COVID infection. But at this point, as I said, potential recipients will be tested for the infection itself. And the antibody testing at this point is not as reliable so that it could be part of a clinical process. I'll finish there and see if Dr. Kumar or Dr. Sridhar have anything to add.
So yeah, thanks, Istvan. So I'll just say that for donation, the most important thing is to make sure that the donor does not have active COVID infection and the recipient does not have active COVID infection. Once those things are clear, we can generally proceed. With regards to antibody testing, and I think Dr. Sridhar mentioned this as well, there are many companies developing an antibody test, and it's not clear right now how good those antibody tests are. When the antibody tests will start to be routinely used, we will actually have to do some more research on them to see how well they work in the donation and the transplantation setting. Antibodies basically just mean that you have had the infection before. At this point, they don't tell you if you're protected from a reinfection, so if you're going to be able to get COVID again, and they don't tell you how long ago that infection was, and they don't tell you how long you're protected for. So the only thing the antibody tells you is that you had COVID before. But the real COVID test that we want to do in donors and recipients is the PCR test, which actually tells you, do you have COVID right now? Because that is the important question at the time of transplantation.
Thank you very much for weighing in. And while I have you at the moment, Doctor, I'm going to also reach out to you with some questions that we've had from transplant recipients about COVID transmission from pets, and also, is it safe to walk their dog? And whether you'd be able to comment on that. Yeah. Thanks.
Sure. Yes, so COVID has been reported in pet dogs and pet cats. You may have seen the news story about COVID at the New York Zoo. Some tigers at the New York Zoo also ended up contracting COVID. So definitely animals, and including pets, can contract COVID from humans and can potentially transmit back to humans. So so one thing is if you do have COVID or if there's a family member with COVID, they should, not only should they avoid other people in the house, they should also avoid their pets. In terms of walking your dog and so on, I've heard the suggestion that, we should be maintaining social distance with, our dogs and cats and so on should be maintaining social distance with others as well. And that's a sort of a prudent thing to follow in this day and age. So I would say, that our pets should be doing similar things that we are.
Okay, thank you very much. And I might just respond to a couple of questions that we've had from people about refusal to work and employers putting people on unpaid leave because of COVID-19. And I'd be happy to take this question. However, I'd welcome the presenters weighing in if they have any other information or comments that they would like to make as well. So basically, depending most provinces will have some sort of mechanism if an employee invokes a right to refuse unsafe work situation, and most of those can be found on provincial websites, and the foundation staff can also help, or social workers can also help with this. Likewise, with unpaid leave or not performing work, there are different layoff rules in all the provinces, and there's slight variations, of course, from province to province. So what you can do is actually reach out to your local or your provincial body that looks after an employment. You can contact your local transplant social worker and get in touch with them. Our staff in our branches would also be very helpful with that because there are a number of options, and it would depend on the provincial situation. I'd also open that up to the other panelists if they have any questions on that.
Not from my side.
Thank you. And just to reiterate, we've also been getting a number of other questions about people who have been self-isolating alone since May, so for example, March 10, that they live alone, an elderly relative lives alone, whether it would be safe to visit them. And I think, it's just reiterating those social distancing guidelines and what it means to transplant patients, because there's still quite a bit of concern about that. And I'd like to open the floor to the panelists to maybe comment a little bit further on that social distancing and what it means for the transplant community.
So again, it's really a risk-benefit, situation. I mean, I think whether we're transplant recipients or not, we want to visit our relatives, especially our elderly relatives. But there's always this fear that we may transmit COVID to them unknowingly, especially if we're asymptomatically carrying it or we're pre-symptomatic with it. So I think it's really a risk-benefit. I think that, as things open up, we will have to consider whether we can go visit our relatives. And again, good hand washing and just keeping the risk benefits in mind would be the most important thing. I'm not sure there's a set answer to that, but I think we all have to sort of weigh the pros and cons of doing that.
Ms. Ramuch, I would continue along with that. I agree that I think there will be changes, and then this situation will have to be weighed. On one of my slides, I mentioned that, of course, isolation will increase stress, and it's not sustainable on the long term. So there were kind of suggestions that after you spend a few weeks in self-isolation with your immediate family who live under the same household, a few numbers, at some point, if others in your closest social circles did the same thing, that you may want to reconsider whether kind of combining those two little islands or circles is risky or not. And I think, again, as Dr. Kumar mentioned, the risk-benefit considerations are important. On the one hand, isolation could be quite detrimental for elderly. At the same time, if you carry the virus into someone's home who is in that age range, that could be quite a significant risk. So that consideration is, I think at this point, there is no science, so it's up to the individual to decide about how they feel about it, what is their risk tolerance, how will they approach this not easy question.
Yeah, very difficult questions indeed, but we thank you for approaching them and at least giving us some sort of understanding with them. Now, I've also had a question which has kind of disappeared in the file because everybody's been asking so many questions today. But I was wondering if our panelists would be able to comment on the use of BCG vaccine and also the use of ACEs and any potential ACE interactions, particularly as the COVID virus does connect to ACEs in the body as well. And I was wondering if you could just explain that a little bit more and comment.
So I can take the BCG vaccine and my colleagues could maybe comment on the ACE interactions. So with regards to BCG vaccine, there has been some suggestion that those that have received BCG vaccine may have some immunity to COVID. And that basically comes out because countries that routinely use BCG vaccine, now BCG vaccine is a vaccine that's given to prevent tuberculosis, for those that are not aware. So countries that use the BCG vaccine to prevent tuberculosis, like India, like many African countries, seem to have a lower rate of COVID. That is an association. It does not imply a cause and effect. There needs to be a lot more research done before we say that people who've gotten this vaccine are immune to COVID. It may be that we're not seeing those numbers from these countries. We're not seeing high numbers because they're just not reporting those high numbers, or they're not testing enough people. So I think that association is out there, but it really does need to be proven. Right now, there's not a lot of proof at all.
I'd be happy to answer the ACE question. So there were some earlier studies, not based in humans, perhaps suggesting that treatment with an ACE inhibitor or an ARB may actually increase viral entry, and perhaps it's worth avoiding some of these medications. At this point in time, further studies are required in humans to support some of these findings. And at this point in time, certainly at Toronto General Hospital and in several large organizations, they do not recommend switching these medications to other drugs at this point in time. That being said, in specific cases, it may be worth discussing with your own transplant team as to whether to stop or continue these medications.
Just a quick clarification, the ACE and ARB medications are groups of blood pressure medications. They reduce your blood pressure, and many patients who had a kidney transplant, they take several blood pressure pills. And these ACE and ARB medications are quite frequently used. And so, as Dr. Sridhar said, it is important not to stop those medications based on news items, and talk to your transplant team if you have any question or concern about any of the medications that you're taking, whether they increase your risk of the disease or not.
Thank you. I think that's a really good point, is to ask those questions of your transplant team, because they know you best and they know your history and your other situation and everything else going on with you. So it's, I think, very important advice that if you have very specific questions, reach out to your transplant team, because they're the ones who will be able to assist you the most. And in the interest of time, this will be the last question of the day. Before we wind this up, I just will move to the next question, and then I'll make some closing comments. So, do you know how many transplant patients have contracted COVID-19 and have recovered?
So I'll try to take that on.
Thank you.
So I think most transplant centers, or many transplant centers, have in Canada have had we'll say a handful of people with transplants who've contracted COVID-19. Around the world, for example, in France, Italy, as well as New York, which have had a lot of COVID, there have been many more transplant patients that have contracted COVID. We are looking at all the reports from around the world on a regular basis in terms of what we can learn about transplant patients who've had COVID. In Canada, we have set up some research in terms of, again, trying to learn from the Canadian experience of transplant recipients who've had COVID. Again, it's very difficult to say how many have recovered and how many have not. And the reason I say that is because remember that the reports that come in are for transplant patients that have seen their doctors or have been admitted to hospitals. There may actually be a significant group of people that have stayed at home, that have had very mild infection that we don't know about. And the only way to figure that out, in terms of, how many actually have had this mild infection, is really to do the antibody testing. So once the antibody testing comes online, once we have a really good antibody test, we may be asking transplant recipients to check whether they have actually had COVID. And then going back and asking people if they remember having symptoms. And I think that's the only way we'll know the true impact that COVID has been having on transplant recipients.
Thank you very much, Dr. Kumar. And I'd just like to say there's just been so many questions today. We've had well over 150 questions submitted online and prior to the webinar, and we apologise if we couldn't get to all of them. But we invite you to connect with us if you have any further questions with our branches, and there will be some emails circulated with how to connect with us following the webinar. But we'd also like to thank the Canadian Society. I'll start again. We would like to thank the Canadian Society of Nephrology and the Canadian Donation and Transplantation Research Program, together with our speakers, for collaborating with us to share this important information with you today. The Canadian Society of Nephrology is a society of physicians and scientists specialising in the care of people with kidney disease and in research related to the kidney and kidney disease. The CDTRP is a national research network designed to increase organ and tissue donation in Canada and enhance the survival and quality of life of Canadians living with a transplant. The Kidney Foundation is committed to providing information and support and educational resources about the kidneys and kidney disease. Through our regional branch offices, we offer advice and support about accessing services within the healthcare system, assisting people to access other supports in their community, and offering assistance in skills for self-advocacy. We invite you to connect with us if you have further questions, to speak with somebody in your community, or to access further educational materials and resources.
Thank you everyone for attending this webinar, COVID-19 and Transplant Patients, Your Questions Answered. When the webinar has ended, your computer will open to a new page requesting that you complete our webinar satisfaction survey. You'll also receive a follow-up email that includes a link to the survey if you would like to complete it later. Your feedback is important to help us improve our webinar series, so we appreciate if you will take a moment to complete it. You will also receive a follow-up email within 24 to 48 hours with a link to view the on-demand recording of today's webinar. On behalf of the Kidney Foundation of Canada, the Canadian Society of Nephrology, and the Canadian Donation and Transplantation Research Program, and our presenters, thank you for joining us today. Stay well and enjoy the rest of your day.